Hello, everyone, and welcome. My name is Valeria Vendries, and I will be guiding you through the anatomy of the vertebral column. Let's first ask ourselves the question, why do we need to learn about the back and the spine? The spine is more specifically known as our vertebral column. Commonly, we know it as our backbone. So it is an important component of our musculoskeletal system. This spine or backbone serves to provide a semi-rigid axis for the body. It helps to maintain and support that structural framework of the body, supports our body weight, helps us maintain an upright posture. It also connects to various other parts of the body. As we will learn, not only it provides this kind of structural stability, but it also allows us to have varying degrees of mobility, allowing for a wide range of essential movements such as walking, sitting, standing, twisting, and bending. Not only that, but learning about the spine can help us understand common spinal conditions. Back pain, for example, is extremely common, can be chronic, and debilitating. Fractures of the spine are not uncommon, and there are other conditions that can cause pain and limit mobility, such as arthritis, back injuries, herniated discs. So, having knowledge of the spinal anatomy can help us understand these conditions and potentially treat them if we are future healthcare professionals. Not only that, but the vertebrae holds and protects something very, very precious. Keep watching if you want to find out what it is. So let's start by looking at the vertebral column. So the vertebral column consists of typically 33 vertebrae stacked on top of each other. They have a segmental arrangement. So in the neck region, we have what we call cervical vertebrae. We have 7 of those, and we name them according to the number. So we have C, as in cervical, vertebrae number 1, that would be C1, C2, C3, C4, C5, C6, and C7, cervical vertebrae number 7. Cervical vertebrae number 1 and 2 have specific names, the atlas and the axis, and we're going to talk about those a little bit more later. Let's move on to the upper back region. That's what we call the thoracic region, and we have 12 thoracic vertebrae, T1 to T12. These 12 vertebrae connect to our 12 pairs of ribs. If we move to the low back region, we're going to find 5 lumbar vertebrae, L1 to L5. These ones are the biggest and thickest of the vertebrae because as we go lower down in the spine, we have increasing amounts of body weight that the vertebrae need to bear. Now we have the sacrum. The sacrum is a single triangular bone in the adult, which consists of 5 fused individual vertebrae. So as we were growing and developing, these vertebrae were separated, but in the adult they become fused to form the single triangular shaped sacrum. And similar to our coccyx, so the coccyx is commonly known as the tailbone, it consists of around 4 fused coccygeal vertebrae. Now, the vertebrae doesn't just stand on itself, it's supported by muscles, joints, and ligaments. So to remember the numbers of vertebrae in each region, I'd like to give you a trick that I use, which is we have breakfast at 7, lunch at 12, dinner at 5. So that can help you remember that we have 7 cervical vertebrae, 12 thoracic, 5 lumbar. Now, I mentioned that the vertebral column is held together by joints, intervertebral discs, and ligaments, and also provides support attachment sites for the supporting muscles that we have. And it's those structures that allow us to move the spine and have those great degrees of flexibility and mobility. So if we look inside, what's going to be inside the spine? So we have this vertebral canal, which is formed when we stack vertebrae on top of each other. What's inside there? So that's the place for the spinal cord. So the spinal cord is that amazing, precious thing that I was talking about earlier. The vertebral column holds and protects that spinal cord. The spinal cord is continuous with the brainstem, which is part of the brain. So here we can see the brainstem, and that is continues with the spinal cord, which ends at approximately the levels between lumbar vertebrae 1 and 2. So the spinal cord is important because it's a conduction pathway between the brain and the body. So instructions about the signals and actions we want to perform, such as moving our arms, starting to run, stopping a specific movement, everything is initiated in our brain, but those instructions are sent via the spinal cord through the specific spinal nerves to specific muscles in our body. We also have sensory information coming in. So, for instance, if you touch a very soft object, that information is going to be transmitted through our spinal nerves, through our spinal cord, all the way to the brain so we can interpret that information. And of course, the spinal nerve also acts as a reflex center. So, for instance, if you touch a hot object with your hand, there's sometimes no time for all of that information to go up to the brain, be interpreted. Then the brain sends a signal all the way down the spinal cord, and then you remove the hand. Really, there's no time for that. So we have a kind of local reflexes that happen at the level of an individual spinal cord segment, such as when that information reaches about you touching a hot object, immediately a response will leave through those spinal nerves, making you remove your hand from that dangerous object very, very quickly. Something else I'll say about this slide. So if we look here, I mentioned the spinal cord ends at the level between L1 and L2 lumbar vertebrae. So what's beyond that? So beyond that, we have a collection of lower sacral and lumbar spinal nerves. This is what we know as the coda equina. Coda equina means horse's tail because this collection of spinal nerves in that region resembles a horse's tail. And in this cross section, I think it's quite nice. We can see the spinal cord being really encased and protected by the bone of the vertebral column. So it is no secret that the vertebral column is not straight, such as what we can see in the surface anatomy of an individual. We actually have what we call these curvatures. And these curvatures are quite important so that we help kind of distribute the weight so that it's not all just loaded in one specific single area, so preventing excessive strain on a single area. They also help to act as shock absorber and distribute forces during activities. So let's look at what these curvatures are. So let's actually look at the fetus. So in fetal development, we know the fetus is kind of positioned in a bent position, bent anteriorly, and it's kind of like this C concave shape. So in the adult, we retain some of that curvature, some of that concave C-shaped curvature in specific regions, particularly the thoracic region and the sacral region. So we're going to call these thoracic and sacral regions the primary curvatures, also known as kyphosis, because they are the ones such as what we see in the fetus. Now, as we start growing and developing, the new curvatures start to form. So, for instance, when a child starts to hold their head upright, the cervical flexure or curvature starts to form. And we also, as we start walking, we're going to see that the lumbar flexure starts to form. So these cervical and lumbar curvatures are secondary curvatures, also known as lordoses because they are kind of more anterior. So here in surface anatomy, we can see that secondary cervical curvature and that secondary lumbar curvature. And we can see the primary thoracic and primary sacrococcygeal curvatures. So there are cases in which these normal curvatures of the spine might become enhanced or exaggerated, and in those cases they start to become abnormal. So one example of such abnormal curvatures is in the case of scoliosis. So scoliosis is an abnormal lateral bend of the spine, such as what we can see in this X-ray here. So one way to pick up scoliosis is to ask your patient to bend forward, and then you're going to see that the right and left halves of the body are not even. One side will be a little bit higher than the other one. When we have an excessive posterior curvature of the spine, we call that an excessive kyphosis. And sometimes we see this with age when the kind of vertebrae start to lose density. Um, so we have this abnormal curvature of the thoracic spine. Now, an excessive lordosis is an abnormal anterior curvature of the lumbar spine, and this typically comes associated with increased body weight in the anterior region, such as in with late pregnancy or in obesity. Okay, so let's go back to anatomy and let's focus on the features of typical vertebrae. So we're going to look at typical cervical vertebrae, which are cervical vertebrae C3 to C7. We're going to look at the typical thoracic and typical lumbar vertebrae. Later, we'll talk about the vertebrae that are not so typical. So, what are the features of typical cervical vertebrae? So the body of cervical vertebrae is quite small, and that's because we don't really need to wear so much. It's not so important for weight bearing. That's what I was going to say. We also have these superiorly elevated processes on the body of cervical vertebrae known as uncinate processes. And those uncinate processes kind of prevent lateral translation of cervical vertebrae on top of each other. Another important feature of cervical vertebrae is the fact that spinous processes are often bifid. So remember, bifid meaning two. So we can see how they split into two. However, this is not always the case. This is very common in white males, but it's less common on people of African descent or females. So don't be surprised if not all cervical vertebrae are bifid if you look at them in the anatomy lab. C7 is also sometimes not bifid, and it's actually quite prominent, that spinous process, because it starts to approach the thoracic region where the spinous processes become longer. So if you actually touch the back of your neck and bend it forward, you might feel a very prominent spinous process. That's going to be the spinous process of C7. Cervical vertebrae are also known for having these foramina on their transverse processes. These are called transverse foramina, and they are there because they allow the passage of these arteries. These arteries are called the vertebral arteries, one on each side. They arise from the subclavian arteries, which leave the heart, and they are going to provide blood supply to parts of the brain. So they're using those transverse foramina to make their way up the neck to eventually make their way up to the brain. Okay, let's have a look at thoracic vertebrae. So if we start by looking at the body of thoracic vertebrae typically has this really nice heart shape. If we look at the spinous process of thoracic vertebrae, it's actually better to see them in this lateral view. We're going to see how they're long and sloped inferiorly. Now, thoracic vertebrae are characterized because they have these costal demifacets. Whenever you hear the word costa, think of ribs. So these facets here, these demifacets, are important points of articulation with our ribs. So we have these two demifacets on the body of thoracic vertebrae and one demifacet on the transverse process of thoracic vertebrae. Now let's move on to look at the lumbar vertebrae, starting with the body. So the body of lumbar vertebrae is quite big, quite strong. Remember, this is because this is the portion of the vertebrae that is most important for weight bearing. And it usually has this kind of kidney shape. Now, the spinous process of a lumbar vertebrae is typically short and broad. So since we looked at those typical vertebrae, now we can focus on the atypical vertebrae. And these are typically cervical vertebrae number 1 and 2. So here in this image, we have a posterior view of the skull stacked on top of C1, which is stacked on top of C2. So let's start with C1. C1 is known as the Atlas. Any guesses as why this might be? So C1 was named after this Greek god, Atlas, who was holding the globe, the weight of the globe in his shoulders. So it's kind of like an analogy in which our cervical vertebrae number 1 is Atlas holding the globe, in this case, our skull. So Atlas is unique because it doesn't have a body and it doesn't have a spinous process. So instead of those, we have an anterior arch instead of the body, with a little anterior bony projection known as the anterior tubercle. And instead of the spinous process, we have the posterior arch with a little posterior tubercle as a bony projection. We also have these lateral masses, which are the points of articulation with our occipital bone in our skull. Let's look at the axis now, which is cervical vertebrae number 2. And the axis is commonly known because it has this tooth-like projection known as the odontoid process. Odontoid coming from the word tooth-like, or dense. So some textbooks might call this the dense of the axis, others the odontoid process. In any case, this is kind of a highly modified version of the vertebral body. This is going to fit with cervical vertebrae number 1, providing a pivot point for our head. So that's why it's called the axis. We're going to talk about that pivot motion in a little bit more. So now let's go all the way down and look at the anatomy of the sacrum and the coccyx. So I mentioned earlier, sacrum is this triangular shaped bone, which is formed by the fusion of sacral vertebrae S1 to S5. The kind of superior and anterior aspect of S1 is a bit more prominent, so it's called the sacral promontory, and it's an important landmark for obstetrics. So this is the anterior aspect of the sacrum. This is the posterior aspect of the sacrum. And we can see these median, intermediate, and lateral sacral crests. So these are kind of ridges of bone. And what are they? So the median sacral crest is essentially kind of the rudimentary spinous processes of S1 to S5, which fused. The intermediate sacral crests are the rudimentary articular processes of the sacral vertebrae, which again become fused. And the lateral sacral crests are the rudimentary transverse processes, which again become fused, forming these ridges of bone. We can also see a superior articular process with its facet for articulation with the L5 lumbar vertebrae. And we can also see what we call these wing-like projections laterally, one on each side. These are called the ala. And the ala have this kind of facet or face for articulation with the hip bones, therefore forming our pelvis. The sacral canal and sacral hiatus more inferiorly are the continuation of our vertebral canal, and they contain those lower lumbar and sacral spinal nerves, which we commonly call collectively call the chora equina. What else can we see? We can see the anterior and posterior sacral foramina, and these are essentially the exit points for our spinal nerves at the level of the sacrum. I won't say much about the coccyx except what I said earlier, that it's this tailbone which is formed by the fusion of four, sometimes three, sometimes five individual coccygeal vertebrae. Let's look at some clinical relevance. So, vertebral body osteoporosis. So, what's this? So, osteoporosis is a disease characterized by demineralization of bones. So, we've lost the balance between um, the position of bone and resorption of bone, in which resorption of bone wins. So it becomes demineralized, as what we can see in this image here. It loses density, becomes brittle, weak, and subject to fracture. Osteoporosis can affect any bone, so sometimes commonly affects the vertebrae, the head of the femur, the bones of the hand. But in this case, in vertebral body osteoporosis is commonly seen in postmenopausal women. And as we can see by this radiograph here, because we've lost so much bone density and the bones become weak, this can lead to excessive kyphosis in the thoracic region. It also leads to reduced mobility, height loss, and in extreme cases, pain. We're going to look at the joints of the vertebral column. So let's start by our atlanto-occipital joint between C1, our atlas, and the occipital bone of our skull. So these joints, as we can see just here, are formed by the occipital condyles of the occipital bone and the lateral masses of C1. So this articulation allows us to nod our heads upside down as if we are saying yes. So it's a highly movable synovial joint. Now let's look at the joints between C1 and C2. These collectively form our atlantoaxial joint. So what are these joints? So we have on each side the joints, the facet joints formed by the union of the articular processes on each side. And we also have a joint between the dens of the axis and the anterior arch of C1. This atlantoaxial joint allows us to pivot our heads as if we were saying no. And of course, this is held in place by ligaments. So we have the transverse ligament and these alar ligaments, which are essentially preventing posterior dislocation of the axis or anterior dislocation of the atlas. Let's look at intervertebral joints. So these are essentially the joints of the bodies of vertebrae, and these are also known as symphysis joints. So symphysis are a type of joints which are essentially cartilaginous joints and are not so mobile. So here we have the body of a vertebrae, and on top of that we can see the intervertebral disc, which consists of two components. An outer layer called annulus fibrosus. Annulus means ring. So it consists of concentric rings of fibrocartilage that are attached to the rim of the body of the vertebrae. And the inner layer is what we call the nucleus pulposus. This is a more gelatinous substance, and it's really what helps act as shock absorber and really provides that flexibility to the vertebrae, to the vertebral column. So let's talk about a clinically significant aspect of the intervertebral discs. So we talked about how they support our spine, helping with weight bearing, providing shock absorbing and flexibility. So this is the case when kind of the loading of the weight is equal all throughout. But in some cases, when the vertebrae are compressed kind of more so anteriorly or more so posteriorly, such as when we're lifting a heavy weight, the nucleus pulposus might start herniating out of place. And it may herniate posterior and laterally, and in that case, it may compress a single spinal nerve. And in that case, it's going to lead to weakness and sensory losses along the distribution of that particular nerve, which is compressing. Sometimes we can have a posterior herniation in which the nucleus pulposus starts to herniate posteriorly. And in that case, it may compress either the spinal cord itself or the cauda equina. So that's a surgical emergency, and it needs to be treated quite rapidly because compression of the cord itself or the cauda equina might lead in paralysis below the level of compression and also issues in bladder and bowel control, also sexual dysfunction. So here we can see an MRI scan of a disc. In this case, it's the disc between L3 and L4, herniating and compressing. Okay, so let's go back to our joints discussion and let's talk about these particular joints called the zygapophyseal joints, also known as facet joints. So these are the joints between the superior and inferior articular processes of adjacent vertebrae. So these joints are plane gliding synovial joints. So these joints are orientated slightly different, and this kind of determines the level of mobility and the level of restricted mobility that we have in each of those regions. So as we can see in the cervical region, these joints are oriented somewhat horizontally, like so. So if I were to put my hands like this, they're horizontally stacked on top of each other. So they allow gliding like this. And that permits the cervical region to be quite flexible, to have various degrees of rotation, flexion, extension, lateral flexion, and extension. However, for that same reason, because these cervical vertebrae are not so kind of interlocked tightly with each other, it's a lot easier that cervical vertebrae become dislocated in comparison with thoracic or lumbar. Let's look at thoracic vertebrae. And as we can see, these joints are orientated in the coronal plane, like so. So if I put my palms like this, they can glide in this manner. So this permits a certain degree of lateral flexion, but not so much. It's quite restricted in the thoracic region. The thoracic region allows more for rotational movements. And if we look at the lumbar region, the facets are orientated in the sagittal plane like so. So they're quite strongly interlocked with each other, meaning that I'm kind of pushing my hands upon each other. It's very difficult that these vertebrae are going to dislocate from each other. Okay? However, that means that we have limited rotation in the lumbar spine. This is, I believe, the last type of joint I will discuss today, the costovertebral joint. So remember, costa refers to ribs. So these are the articulations between the ribs and the vertebrae. So the heads of every rib articulate with the bodies of the thoracic vertebrae above and the thoracic vertebrae of its corresponding rib. So, for example, in this case, we have rib number 7. So the head of rib number 7 is articulating with the inferior costal demifacet in the body of the vertebrae above, in this case T6, but it's also articulating with the superior costal demifacet of the corresponding vertebrae. So in this case, because this is rib number 7, it's going to articulate with thoracic vertebrae number 7. There's one more point of articulation, and it's between the tubercle of a rib, which is this kind of bony projection as the rib starts to angle away from the spine. So that tubercle articulates with the transverse process of its corresponding vertebrae. So now let's look at ligaments. So what are some of those key ligaments of the vertebral column that help stabilize it but also prevent hypermobility in some directions? So this anterior longitudinal ligament is the only ligament to prevent hyperextension of the spine. This is the posterior longitudinal ligament, and it's there to prevent hyperflexion, and also it's there to prevent posterior herniation of the intervertebral discs. So, reaching the end of our session, let's talk about the different movements in the vertebral column. So, the movements that happen at the level of the vertebral column include flexion and extension. We also have a lateral flexion when we bend the body either to the right or to the left away from the midline, and lateral extension when we bring it back to anatomical position. So these movements primarily occur in the cervical and lumbar regions, which are the most flexible. And again, this relates to the orientation of those facet or zygapophyseal joints. It also relates to the thickness of the intervertebral discs at that particular region. So cervical and lumbar are the most flexible, and the thoracic region is actually the most limited in terms of movement. This is because of the orientation of those joints, but also because it's quite secured with the ribs and the sternum anteriorly. So that also helps limit movement in the thoracic spine as a whole. So in the thoracic spine, we really only have some degree of rotation, and we also see rotation at the level of the cervical spine. We don't really have any degree of rotation in the lumbar spine because of that sagittal orientation of those facet joints, really preventing any rotation at that level. So you may want to fill out this chart or this table. In which you are welcome to write down the features of individual vertebrae and how they compare to each other. So, how does the body of a cervical thoracic vertebrae differ from each other? What about the spinous processes? What about the movements possible at each of those regions? So, you may wish to fill in this table. And just to summarize, let's see what we've talked about so far. We talked about the components of the vertebral column and the landmarks of each vertebrae, curvatures of the spine and their significance. We looked at joints, ligaments of the vertebral column, movements of the spine, and all throughout we talked about common injuries and clinical relevance of many of these structures. So thanks for watching, and we'll see you next time.